Right, so first things first, congratulations all of you on passing 5th year, which is why you're here in 6th year, well done. And it has been a really weird 5th year that you've had. Hopefully it will be a more settled 6th year, and a little bit of what we talk about and how this year runs is impacted on how your 5th year has run. And so that's just something that you guys will need to be mindful of. So you have a 4-week psychiatry module to start off the year before Christmas. And I guess the way 6th year is set up is quite different to the way 5th year is set up. So the key difference here, the key thing to think about is that in 6th year, the university has really specifically said now, and is correct, that you are like apprentices. So you've passed the big exam. The presumption that we have is that you have the knowledge required to be a PGY1. This is the year for you to refine that knowledge and, most importantly, learn to individualise that knowledge to the people that you are seeing and treating. So that's the kind of key purpose of this year. In essence, all of the assessment and almost all of the modules is geared towards doing that. So this is quite a different year from 5th year, and so there's a far greater expectation for you to be able to kind of work to be individualising what you already know into the practical application of medicine as a PGY1 primarily. So that's kind of how you need to start to be thinking from here on in. I'm just gonna, there we go, which is what this says, right? And so that is kind of the key thing to be doing. The way you do this best is by simply embedding yourselves as much as you can within the teams to which you're allocated. So you want to make sure that you are going to your multidisciplinary team meetings, seeing patients and spending time, reviewing notes and checking up on what's happening with the people you're engaged in. It's abundantly obvious to us who is spending their time on the ward seeing people and who is not spending their time on the ward seeing people. So that is going to be something really important for you to be focused on this year. You have 4 tutorials of this, which this is the first one. And this year what we've done is aligned the teaching in psychological medicine across all 3 schools. So in essence, what you get, what they get in Christchurch and what they get in Dunedin is now largely the same. I mean, obviously the individual experiences will be slightly different because you're all going to be with slightly different SMOs. But in essence, the experiences that you're getting in terms of teaching and examination are now the same. And so in psychological medicine, what we really want you to do is take that book knowledge and focus on people in a biopsychosocial way. So I want you to be thinking hard about some people in detail to try and figure out what's going on with them from a psychiatry perspective, what's going on with them from a psychological perspective, and what this means for their life. So most mental health problems that you're going to be seeing and thinking about at the moment have a degree of chronicity to them. And so that's the reason for kind of doing this. This run, like ONG, and I can't remember what the third one that we share with, is short at 4 weeks. So if there are any issues or problems, I need to know about them soon so I can do something about them. It doesn't happen very often, but very occasionally, either an SMO will be away for a large majority of the time and simply have forgotten to tell me. I've never had it yet, but there may be significant personal or interpersonal problems, whatever it is. I need to know. I can't do anything about problems if I'm not made aware of them. Almost always that is not an issue, but it is something to be borne in mind. The other thing you'll notice when it comes to the various bits of requirement in terms of passing this is that these are clinically oriented and only relate to, in essence, really a few people. Now, there's a reason for that, and that's that we expect you to, when you see and assess somebody, to then spend some time thinking hard about what all of this means. When you do EAC, I think you've got to put 70 cases in your logbook, which there's a lot of seeing and sending away, which is not what we do. And so there's a reason that you see fewer people here, and that's because we expect a greater degree of detail to you. And so when you're coming up to thinking about the various bits and pieces that you're doing, it's important that you do that. It's, and so when you're on the wards, the key thing to be doing really is going to be interviewing people. It doesn't matter where you are, there should be plenty of opportunity to do this. There'll be plenty of opportunity also to kind of get engaged with some of the other experiences that might be available to you. So there might be things like, I don't know, a home visit to do a formal occupational therapy assessment, or to be involved in someone's, say, getting neuropsych, or having some therapy or structured therapy delivered to them, or whatever it might be. And I think if those opportunities arise, I'd encourage you to take them. If those opportunities arise and it means you can't make it to a tutorial, I guess you get to make a decision about how your learning is best, your time is best spent for your learning. But I think you're probably better off making the most of those opportunities as they bring themselves to you. In essence, this is the last formal psychiatry teaching you will get outside of continuing medical education unless you do psychiatry. And almost no matter where you end up practicing, you're going to see plenty of people with psychological and psychiatric problems. So it's a good opportunity to have a feel for what some of those specific types of things can be and can do. It's, you need to do some call. And so you guys are all in Wellington, which makes it easy. So call for you is simply one day after hours, Monday to Friday, that runs from 2:30 to about 10:30 or 11. The Crisis Resolution Service have a handover at 2:30 at Pairua, and I would encourage you to be there for it. They are just going to do their normal job, right? And it's a bit unlike being hospital-based, because actually a lot of what they do will be out and about, seeing people in their homes, seeing people at the police station, whatever it might be. So if you're there for the handover, you get to hear and see what's going on, and then you can essentially make yourself available to whoever it is who's out and about doing some stuff. There are generally 2 teams of nurses out doing things and 2 registrars. So there's often lots going on. Those people are just going to get on with what they're doing. It's kind of up to you to make sure that you tag along with them. It's for most of you, this is going to be the opportunity to see somebody who presents acutely distressed with suicidality, and it's a really important thing to have a feel of, and something you will see, as a PGY1 almost certainly at some point throughout the year. So kind of important to do. You also need to do one weekend day. That can be a Saturday or a Sunday. I recommend you do that from, I think, handovers at 8 for the day. Unlike during the week, I think the best thing to do then is to call in. So there's a number on the sheet you need to sign, to call in to find out what's going on. Now, the reason for that is the team does meet, but obviously it's a smaller team, and they're going to prioritise the order of jobs they have to do and go do them. So, if they're in Pairua, there might be someone to see in Kapiti, there might be somebody to see in Wellington, there might be 3 people waiting in ED, for example. And obviously, if you live in Newtown, you don't want to drive all the way out to Pairua just to turn around and drive all the way back in and see people here in the hospital. There'll always be something going on, almost always. And there'll almost always be something going on that's suitable for you to go along to. So occasionally some of the crisis team will say things to you like, well, there's a bunch of stuff going on, and when I come across something that's appropriate for you, I'll give you a call. Everything's appropriate for you, basically. This is your opportunity to get that experience. So I'd strongly encourage you to just tag along. Again, if there are any problems on call, let me know. Not every call is flat out. Very occasionally, there's a call where basically there's nothing going on. And if that's the case, that's the case. With relatively few of you in Wellington, it's relatively easy to find another call if you want to do more. And so it's important to do that. In terms of stuff you need to hand in, you need to hand in to me 3 formulations. We're going to talk a bit about formulation after this. And we're going to use those formulations as the basis for your Viva examination. Formulation's not a case history. And And so it's important that you spend a fair bit of time thinking about those as you construct them. Strongly encourage you to wave them under the nose of a registrar or consultant to get their view on what you've done. And most are very happy to do that. You need to have those formulations to Kerry by Wednesday at 5 o'clock at the latest. If you don't have those formulations to Kerry by 5 o'clock on Wednesday of week 4 at the latest, I withhold the right not to examine you, which means you'll be incomplete until I can examine you. And the reason for that is that I need to read all of these formulations to make sure that they're up to scratch, and whoever is examining with me needs to do that too. We both have full-time jobs, and so you need to give us enough time to do that. That is important. Your formulation should be no more than 1 page, 12-point print. I don't really care what typeface you use. I've had someone hand in a formulation in 6-point print, which is virtually unreadable. And if you write 2, yes, crazy, but you know, if you write 2 or 3 pages, I'm going to read the first one and bin the rest. So it's important that you learn to be concise in your writing. And so that's what you need to focus on doing. A formulation does not have to be a whole page long. Sometimes you can get across what you need to in less than that. As a general rule of thumb, your TIs, as your formulations are better and better and better, your Viva examination is easier and easier to pass. Usually because you spend more time thinking about what's going on for this person, which is pretty obvious. You need to present 2 cases to your registrar or consultant, and those can be done in your supervision or at other times. So you should get an hour a week with either a registrar or a consultant, and I'd use that time to do things like present your case histories, talk about your formulations, and talk about weird stuff you see that's going on that you don't understand, of which there will be plenty, and they should be able to help explain to you kind of how things are functioning wherever you are. The kind of key bit of learning to be getting on with in the next 4 weeks is, unlike 5th year where the learning was content focused, now the learning is process focused. How do I take this big pile of knowledge that I presume you have and apply it to these patients? So it doesn't really matter if you're seeing forensic patients in Prahirehu, you know, kiddies in the community, acutely unwell patients on the ward, doesn't matter. That process of individualization and application of knowledge is exactly the same. And that's why it's important that you do that. Really, really importantly too, you are responsible for collecting all of the little bits of information that you're going to need to get to me and get up onto Moodle to make sure that I can pass you. That's really important because we need to collect all that information to make sure you tick the boxes to get over the loop for this year. Have you guys been told about these mini CEXs that you've been asked to do? Thanks. I don't know how, you need to tell me if I'm pronouncing your name right, Sven, but has anyone been told about them?
Don't think so.
Okay, I'll write to Rebecca and find out what the story is then, and won't talk to you about those now. Don't worry about it. Okay, so that's kind of what we're going to do. All right, in terms of the stuff you have to do to pass, this is what it is. I don't know how much you guys talked the year before you, but there have been some changes to how things were last year, and that's mostly to make sure that we align our assessments across all 3 schools so they're exactly the same. Okay, so the first thing you need to do is complete a PASAF. Those PASAFs are online in Moodle. Kerry will be sending an email to each of your SMO supervisors that has a link to this PASAF. What they're going to have to do is push the link, up will come the PASAF, and then go through it. There are 4 domains in that PASAF they need to mark off, and then there's places for free text so they can make comments. They should be doing that with you. I cannot pass you if that is not done. And the responsibility for doing that is not your SMOs, but yours. You need to make sure that they're all over it and that they get it done. If for any reason your SMO can't do it, and sometimes I get things like, you know, an SMO is here for the first 3 weeks, goes away for a week and gives, passes you on to another SMO to look after for the last week, for example. That new SMO won't have the email with the link, right? And if that is the case, then you're going to need to talk to Kerry or me to make sure that we can get the passive link to the right SMO so it can get completed. A registrar can complete your passive. It does not need to be a consultant. So that's the first thing you need to do. They have been done as paper passives up to now. So the university wants all of this stuff to end up on Moodle, so to become a paperless system, which is why this change has happened. Your SMOs know this change is coming, but some of your SMOs like me are a bit old and stuck in the mud, and we like to do it the way we've always done it. So it's going to be when, you tell them that they should have had an email link, and I go, oh. You just need to, you're going to need to hold their hand a little bit to make sure that they get their emails and find the link and open the link and do it. It's really easy, just different. So it is important to make sure that that is done. The way the system is set up means I can't pass you guys unless all of these things are now done online. So they're going to have to get done. So that's the first one. All right, the second thing you need to do is a Viva. These Vivas are now 10 minutes long. They occur at the end of the run and run on the Friday morning. So that'll be on the 18th. These Vivas are all done by Zoom. So you'll Zoom in, you'll see me and one other examiner. One of the two of us will run through the domains which are in Moodle, so you know what we're going to ask you. And what we're going to do is examine you on one of these formulations. We will choose one and we will tell you which formulation we're going to go through. You're allowed to have the formulation in front of you so long as it's a clean blank piece of paper with only the formulation and no notes scribbled on it. That's okay. You can't have lots of notes scribbled on it. Obviously, you can't have your textbooks and stuff open in front of you. Although my personal view is in 10 minutes time, they're going to do you more harm than good because they'll slow you down so much. There are 4 domains that we examine you on. You can find those domains in Moodle. Yep. So the key here is to be prepared. You are really going to struggle in a 10-minute Viva if you're not all over this. So you're going to need to have a really close look at what those domains are. You're going to have to make sure you've thought hard about your case. You're not going to have time to waffle around. We're going to ask you a question about diagnosis and differential diagnosis to start off with. You're not going to have time to work out what you think your diagnosis and differential diagnosis is on the hoof in the Viva. If that's what you're planning on doing, there's a very, very good chance you won't pass. So you're really going to have to put in a little bit of time to make this fit. If I was you, I would very strongly encourage you to practice this. This will be markedly more challenging than the OSCEs that you didn't sit. So you're going to have to be onto it because the time is so short. And you'll see some of those domains there in Moodle are not small. It's, I don't know if you're checking your emails, Fiona, or looking at them, but you'll see that, we're going to ask you about management. I could probably spend half an hour talking about management for virtually anybody. You're going to have about 3 minutes to wow me with your knowledge and individualized understanding of management for whomever we talk about. Yep. So you're going to have to be onto it. Experience tells me that Vivas are much easier to do if you've thought hard about your formulation. So I'd really encourage you to think closely about that. So that's kind of important. So you're going to have to complete a passive, you're going to have to complete a Viva. You all need to complete a recovery reflection. So from 11 to 1 and then 1:30 or 2 till 4 or 3:30, you'll get a tutorial today from the World of Difference team. There's a variety of reading for you to do as well. And you're going to have some experience at a patient-led NGO on this run. And essentially what we're expecting you to do is take all of that, bundle it together and have a think about what that means specifically from a kind of a stigma human rights, long-term recovery perspective. Those formulations need to be handed in by the end of week 2. Tracy will then mark them at the end of week 2. And if they're not up to scratch, we'll give them back to you with pointers about what to do to get them up to scratch. The reason we do this for the formulations is that it is difficult. We've discovered this is a different kind of learning from much of what you've done. It requires you to kind of think about this in a slightly different way. And for a not insignificant minority of 6 years, it's quite a challenge. So, a fair chunk of you often have to get it back, have a little bit of think, do a bit more of a reading, and put it back together and get it back. And so by handing it in at the end of week 2, there's plenty of time for you to do that. Much like all of the examining this year, I'd think of all of this as being like formative examining, right? This isn't so much something you pass or fail, it's something you've got to get good enough to move on. And that's actually what life is going to be like for the rest of your professional life as a doctor. You know, you just got to get to the point where you're good enough to make the next step into whatever the next step is. And so with the recovery reflection, it's just that opportunity to do that. And so it's important that you get that done. The last thing you'll see you have to do are some 360-degree assessments. Have any of you ever done that before? Do any of you know what they are? No? Okay. So a 360-degree assessment is a type of assessment which is becoming increasingly common in many medical workplaces and increasingly required by some of our colleges. So it's something that's kind of good to get into the habit of doing. And the purpose of this is to get an overview of others about how you're doing in a 360-degree way, so from everybody. So what you're going to need to do for 3 of your 4 weeks is get a patient to fill out an assessment of you. These assessments are found in Moodle, they're Word documents. You just need to download them, get a patient to go through it and upload it. You also need to get 3 of the staff that you're working with to do these slightly different assessments. And they have to do the same thing, fill it out, give it back to you, and you get to upload it, right? It's so you're going to upload 6 of these in total, and this is a way for us to see that you've been engaged with a variety of staff and patients and to get a feel for what they are thinking about you. Again, this is a type of summative assessment, type of formative assessment. So what you're doing is you're going to build on these over the years, and it's a way of monitoring your progress. So that's the primary reason for it. It feels like a bunch of stuff to be doing, and I guess the important thing is to be on top of it early. So you should be doing 2 of these a week, as well as working on your recovery reflection from this week, as well as writing a formulation each week. So, you know, it's a fairly structured approach to making sure all of that stuff is occurring. Your SMOs know that you need a kind of a balance of time between seeing patients to do these variety of activities, seeing patients for learning, making sure you've got enough time to do things like see a patient, read their notes, see them again possibly if you need to, go away and do some reading in the library about what's going on for them, write a formulation. So they know that there's a bunch of this other stuff you need to do, as well as a little bit of service delivery. Your SMOs will reasonably ask you to go and do some stuff, and you're going to have to be up for that. And you're also going to need some time to make sure that these various assessments get done. You know, we scoop all of that stuff together, do the vivas, work out what your grades are, and tell you. Essentially, the way you get you are graded this year is you either pass or you don't pass. So normally you pass, or you get something called a conditional pass. That means that you haven't passed yet, but if you meet whatever the conditions are, then you will pass. So that might be about, you know, doing a satisfactory viva because your viva's not up to scratch, or whatever it might be. Or you get incomplete because part of what needs to be done to mark you, I don't have. And very rarely people fail runs, but it's extremely uncommon. So you should kind of think about this as making sure you're checking the boxes, working on getting the stuff that you need to get done. My approach to this is to tell you all your grades at the end of the module together. So I need all of you to have your passives back to me, and all of you to have uploaded your various bits of assessment before I give anybody their grade back. So it's just important that you're kind of holding that in mind. Does anyone have any questions about any of that stuff?
I have a question about the case histories. Are these like observed interviews, or do we just do like a case history and then present back?
Yeah, so I am very jiving, thank you. I'm very comfortable for you to go and see someone and take a history. You will discover lots of the SMOs quite like coming with you when you do that. So they're going to come and observe you anyway. And then you write that case history up and then present it to them in one of your 1-hour supervision sessions. And it's a good way really to talk about someone who is hopefully who you find interesting, but also who raises some questions in your mind. Like you might be wondering, why is this person in hospital, or why is this person not in hospital, or whatever it might be. It's that's how I would make the most of this opportunity. It's and the other thing I haven't said, but is worth bearing in mind, is that what we also expect of you this year is a bit of common sense. So for example, if you're seeing a patient who's 40 and got a 20-year history of paranoid schizophrenia with some pretty standard, signs and symptoms of their schizophrenia, and they come into hospital with their standard signs and symptoms of schizophrenia, I don't want to hear you think that they've got a differential diagnosis of, schizoaffective disorder, depression with psychotic features or whatever. They haven't. They've really got a diagnosis of one thing, haven't they? Paranoid schizophrenia that's relapsed. They may have a comorbid problem, brain tumor, cannabis use disorder, whatever. But and so it's an example here where we don't want you just to spew out everything you know. We want you to think about how you individualize the information that you have. And those case histories are a good way to work on that. Is it G-fing or G-fing? I'll get there eventually if I'm lucky. That's so G-fing, jolly good. All right. Okay, I think I've got you now. Yeah, so that's the reason for it. Any other questions or queries? Jolly good. All right. So let's try doing this. Okay, so what we're going to do for the rest of the time I have with you can see these slides now, guys. Cool. Is we're going to have a very brief think about diagnosis, formulation, and management. I'm going to try to get through this in about 45 minutes. So I've kind of varied the length of time I've done this from sort of 40, 45 minutes to a couple of hours. There seems to be no benefit from making it long and perhaps less. I've even mused about not doing this at all, just having these in Moodle for your reference, but haven't done that. I think these are in Moodle for your reference, but if they're not, let me know and I'll make sure that they get in there. Importantly, there is nothing in these slides which is new. You know all of this stuff. I know you know this stuff because I taught some of this stuff, not to you, but I've taught it to other groups in 5th year. So you know this stuff. Don't worry about the fact we're not going to get to the end of it. The reason I've left it here is so you have it as a reference. We're not going to do that anymore or that. What we are going to do is just get into it. So this, like all of the cases that you're going to talk about here, and in your next 3 tutorials, you're going to have an hour of kind of talky teaching and then an hour of cases. These cases and the cases you'll talk about are going to be, real people you're seeing. So it's just important you remember that when you're kind of doing the whole, going to talk about work at Beaver Moss like you will do and that kind of stuff. You don't want to be talking about these cases in places where these cases might be sitting around listening to you. So it's important to remember that from a privacy perspective. Because there are only 6 of you, this is going to be a little bit of a challenge for you, G-Thing. But Luke, you've got a microphone, eh?
Yeah, no, I got a mic.
Cool. Okay, so it won't be so bad for you. So what I'm going to do is you can all see this case, Janine. I'm going to leave my office. I'm going to leave you all in here. And as a group, what I want you to do is work through this and work out your preferred diagnosis and differential diagnosis for Janine. Now, the reason for this is when you're seeing patients over the next 4 weeks, this is the sort of thing that should be going through your head. What is going on? Right, at your stage of learning, this is where you really need to be focusing. What is my preferred diagnosis? What are the differentials? So what I want you to do with Janine, I'm going to give you about 10 minutes, is to think about your preferred diagnosis and differential, okay? You can do this together. G-Fing, you'll need to type to everyone in chat, so everyone's going to have their chat open so you can engage with G-Fing. There won't be any other way of doing it, I'm afraid. I am going to go and tell Kerry that I'm going to have to ask everyone to make sure they've got a camera and microphone, which I've never done before, but I've always assumed that everyone would, which is stupid of me now I think about it. And so I will be back at Yeah, 9:47. Okay, you're all clear about what you need to do? Cool, see you in 10 minutes.
What do you guys think?
We're thinking maybe major depressive disorder. I think Moni just sent to the chat for
Oh yeah, should've.
for like maybe the diagnosis. I'm not sure. What have you got any ideas for differentials?
Could be PTSD since she saw her mother being abused when she was younger. And
Oh
stuff.
yeah, good thought.
But yeah, most likely major depressive disorder, I think.
I also think maybe there might be like an element of like borderline personality disorder with the all but one social worker and like the frequent
Yeah.
relationships.
Yeah, that's a good point.
Any other ones?
Could you also consider like a physical cause because she's got like weight loss and like frequent ill health?
Yeah.
What sort of physical thing are you thinking of?
Not actually sure.
Thyroid.
Brilliant.
Surely.
Hyperthyroidism. Substance abuse, maybe. I don't know about that actually. Overdose of child sleeping tablets. That might just be depression.
Surprisingly, there's no mention of alcohol or drugs in her history.
True.
Surprisingly.
Where do intense relationships come from again? Does it, how, is it a sign of bipolar?
I was thinking perhaps it might be closer to the personality disorder.
Oh, okay.
Do we need a suggested treatment or?
Pregnancy test?
Yep.
Check for thyroid stuff. Whatever the tablets she took, I guess. I guess social workers for the daughter.
Alcohol, drug history. Yeah, I guess you want to explore the overdose more, like suicidality sort of questions.
Yep. So just to summarize, we think that she's likely got. Sorry, 1 second. Yeah, those are good points, Stefan. So just to summarize, we think that this is likely a major depressive episode with a suicide attempt. So under history, things that we need to ask. Need to explore first, I suppose, depression history, also a suicide risk assessment. Other things we need to find out. We need to take a full drug alcohol history, find out what sleeping pills she's referring to. We also need to do some tests like check her thyroid function. Anything else?
I think that sounds really good.
What would be our lead differentials? Have you guys still got your 5th year student workbook?
I do.
Great.
I'm just leafing through it.
Yeah, same.
With all the physical symptoms she's having, would we consider all like a somatic symptom type thing? If there's no page numbers on this book. Oh, there is page 117.
117. Let's go have a look at it.
I feel like bipolar might be a differential, but I'm not completely sure what you guys think, because
Yeah, I reckon it could be. I guess we just have to ask about any like manic episodes as
Yeah.
part of the history.
it might not be manic, but like hypomanic, like not so intense, I guess.
Yeah, true.
Yeah. So, but you still need to ask, I guess. So differentials, we have bipolar, which we can rule out if she doesn't have any manic or hypomanic symptoms.
The personality disorder one could be the differential. I think.
Yes, so how much do you guys know about personality disorders?
Not much.
Not a whole lot, but like I feel like borderline is
So this
probably
does
the one I know more about.
it does sound a little bit like borderline, in the sense that borderline typically have suicidality
Yeah.
as one of their key presentations, and in specific to do with it past, having intense relationships is a very borderline sort of thing to do.
And like also I think the all but one social worker putting her down, telling her she's a bad
Yes.
parent. Like, I think that's also quite characteristic.
Yeah, that is, yeah.
Yeah. But I mean, it could be like a comorbid thing and not like a. I mean, you could have both at the same time, like depression
yeah.
and personality disorder.
Right. When presenting, we'll say something like, "We're thinking this sounds a bit like a major depressive episode, but there's sort of a hint or some sort of aspect of borderline personality at play."
Yeah.
Right, so first line treatment for depression, SSRI. Should we go with, I don't know, citalopram? I'll go look up NZF.
Should be that.
Right. We have a heroic volunteer. Who wants to present to me your preferred diagnosis and differential diagnosis?
Sure. So we were thinking this sounds a little bit like a major depressive episode.
Yep.
There's sort of an aspect that, from the history, it sounds a bit like she might also have sort of a borderline personality disorder as well, perhaps.
Okay.
But our other differential would be bipolar, and would want to take a full history and work out if there's any sort of manic or hypomanic aspect to things.
Really good. That's as far as you got.
Other things we thought about could have been like hypothyroid, so could check her thyroid status. And we discussed a bunch of other things, but didn't quite feel like they fit properly.
Really good. All right, I want you to pick one of your colleagues, Luke.
I don't know why. Okay, I'll take Patricia because I know you, Patricia. Sorry.
All right, so Patricia, what I'd like you to do is to tell everyone what is really good about your preferred diagnosis of major depression and your two differentials of borderline and bipolar and maybe hypothyroidism. So what are the good things about this?
The good things.
There are some.
I guess if you come up with a diagnosis, you can start with your management plan and treatments, if that's what you mean.
Okay, I'll ask you the question in a different way. Sorry for not being clear. So I guess you could have gone for tons of things. What is it about the differentials, the preferred diagnosis and differentials you have chosen? What I want you to tell me what is really good about this list. So what is it that's made you decide on, major depression and borderline and bipolar? That's.
I guess she has a lot of the different symptoms, and the time frame fits as well. So she has a 3-month history of lower mood.
I'm going to stop you because I trust that you know. So it sounds crazy, but they are really, really important things. So making sure somebody has the symptoms. So you have identified the psychopathology correctly, and you've identified the time frame correctly is really important. What are the other two things you need from almost all psychiatric diagnoses?
That it's not caused by a organic disease or other substances.
Yep, and the other thing?
There's no other underlying psychiatric disorder.
No functional impairment, not no functional impairment. So it's got to cause problems. So yeah, you always need those 4 general things. So one of the really good things here is you've got a preferred diagnosis with a bunch of symptoms, and she's had it for long enough, right? And if this was your viva, I might say, well, what's the minimum length of time you need these symptoms for a diagnosis of major depressive episode? And you're going to say to me,
2 weeks.
That's right. So it is not that you don't need any knowledge to do well in 6th year. Actually, you need lots of knowledge. You just need to know to make sure you know how to apply that knowledge. Okay, so I agree with you. That's one of the really good things about this. You've identified some differentials that would fit these symptoms and the time frame works. Yeah. Other good things?
She has a family history of depression. Her childhood was quite. She had a lot of traumatic events in her childhood that could carry on her later life.
So why are those non-diagnostic, non-symptom identifiers of relevance?
So childhood traumatic events in childhood could impact later functioning, I guess. Is that what you mean?
They could do.
So she might have poor coping mechanisms, so predisposes her to depression later on.
Okay, jolly good. All right, Min, is it true? Does childhood trauma increase the risk of adult depression? Because that's actually what Patricia's saying.
I think so.
All right, and if I ask you the question in your Viva, you're going to say to me with confidence?
Yes.
Okay, so in your Viva, don't lie. So the way you are really going to get into trouble as a PGY1 is by being too confident, okay? So if you do something as a PGY1 or as a very junior registrar and something very bad happens, if I am your consultant, this is my problem. Yep, and this is true of all areas of medicine. So it's really important that you know what you don't know, okay? So if you don't know if early childhood trauma leads to later depression, you can say with confidence in your Viva, it's that it has reasonable face validity, that you'd expect it might, but you don't know for sure. For example, yep, because that sounds like it's the case. Whereas, is it Fiona? No, that's not right. How do I pronounce your name?
No, there.
I wasn't even close, was I? What is it? Fleur?
It's a difficult, no. Finula?
Fanula.
Finula, like Finula. The spelling makes it worse, so I think it's hard on Zoom.
Fanula, it's not fair. Everyone gets my name wrong. It's slightly irritating, so sorry, Fanula. That's two of this group. That's terrible. Okay.
It's all good, it's difficult.
So, I've forgotten what I wanted to ask you now. Damn it.
Yay.
Completely lost my train of thought. Yes. So does a history of trauma lead to later adult depression? So if you're not sure, say you're not sure, say how much you are or aren't sure. So the other thing that was mentioned was a family history of depression. So I'm going to ask you, does a family history of depression increase your risk of later adult depression?
I'm also not sure, but I believe it. I believe it does.
So it does, yep. Okay, absolutely right. So you just kind of want to be confident about where the limits of what you know and don't know are. So what this does is this is showing you how a little bit of understanding of epidemiology, a little bit of understanding of genetics makes a difference to what you are doing. Yep. And so again, that's really good. There are symptoms and a time frame and the information you have for the gene that would fit with your primary diagnosis of major depressive episode. There are also some peripheral factors that increase the risk. So put her at a greater risk categories than, say, the general population. And you've identified two of those: early childhood trauma and a family history of depression. Yep. So I agree with you. There are some pointers here as well as some specifics that would suggest your preferred diagnosis is right. So I agree. All right, Patricia, you get to pick on either Min or, oh God, I've forgotten how to pronounce it already. Fanula, is it Fanula?
Finula.
You get to pick on either Min or Fanula. I'm going to ask a question too.
Minnie.
So pleased. Okay, so what is not so good about your list, your preferred diagnosis, and particularly your differentials?
We included the bipolar affective disorder in our differential, and we don't have any information about any manic or hypomanic symptoms.
Okay. That is true.
Yeah. I
So
feel like we also don't have any information.
Why'd you put it in if there's no information about mania?
It could be that the information just wasn't provided in the STEM, or just not picked up or asked about, perhaps.
And so I actually think it's a really good thing you've included it, and that sort of information may not be provided. And although I'm not sure if you guys recognize or not, we are better at providing some information than others, all right? So I may not see episodes where I'm kind of, spend a lot of money, I'm really happy, I don't need to sleep, and I piss people off. I might not see that as a problem, but other people will see that as a problem. And then you can start to build up a picture of bipolarity, and it's going to make a real difference in terms of what we're going to do, right? So it's something to notice, yep. other things that you think are maybe not so good about this, your preferred diagnosis and differential?
We also don't know about any substances that she's using, like her alcohol intake or other drugs, so we can't rule those out yet.
The thing is Min right? Do you know nothing about her substance use? No, that's wrong. You do. Luke, what do you know about her substance use?
Let's see. I know that she's taking sleeping pills.
Very good. So you know something about a substance she's taking, right? She's taking sleeping tablets. She must be, because she took 12 of them. Or at least it's a pretty good guess that she is. And if she is not prescribed sleeping tablets and she's acquired them illicitly, then that massively increases the risk that she's using other substances too. She must have got them off someone. Right, so you know something about her substance use history. You know she takes sleeping tablets. As it so happens, they are illicit prescribed psychoactive drugs, but your brain doesn't really care if it's legal or illegal. It just cares what's happening to it. Yep. But you are right in noticing that we don't know anything about her alcohol or other illicit psychoactive drug use. Yep. And actually, it's important to always think about substance use disorders. Why is it always important to think about substance use disorders, Min?
Because I guess they can mimic other psychiatric disorders as well.
Absolutely. They're great mimics. So they look like everything. And so it's very hard to rule them out on the basis of history alone. And so for almost anyone, you should be thinking about them. The other thing to bear in mind is that substance use disorder is common, right? And the old adage, common things occur commonly, is true. Yep. So in the average population, about 10%, if we believe Professor Salmon down in Christchurch, who's an addiction psychiatrist, who's a professor of psychiatry, 10% of New Zealanders will fulfill criteria for an alcohol and other drug use disorder at any one time. Just freeze the clock and count now. And that is heaps. Yeah. If I go to Greece, the study's never been done as far as I'm aware in New Zealand, and I just do a round on a medical ward, half that ward will fill the criteria for an alcohol or other drug use disorder. Now, obviously, it's somewhat culture bound, but you can be reasonably confident that significantly more than 10% of anybody on a medical ward round is going to fulfill the diagnosis of an alcohol or other drug use disorder. And you can watch with curiosity about how often it's asked about, because I bet you it's asked about virtually never. And it's just an example of how it's important to be thinking about the omissions as well as the things that are obvious. So I agree with Patricia. It's really good that you identify some good symptoms and time frame that fit with your preferred diagnosis, major depressive episode. It's also important in psychiatry, but everywhere really, to think about what are the omissions? What would I expect but don't see? And a little bit of this is about good screening. So what does I need to be thinking about? So, you've identified two things which need thinking about and screening for Janine. So one is manic symptoms and the other one is the use of substances. Yep, so they're both important. And I agree with Ji Feng. There's one other important thing that we need to think about here that we didn't mention, and that's that she might be pregnant, which in and of itself is not a mental health diagnosis, but is important to think about. Any other final comments about Janine, who we'll come back to? So this is what we've just done. Okay, these are the reasons for making diagnosis. So a kind of a core part of being a good doctor is being a scientist clinician. What you should be doing is practicing on the basis of the information and knowledge we have. And as you go on further and further in medicine, you're going to get better and better at the art of medicine. This smells like whatever it is, and you'll know because you will have seen 10,000 people prior to the 10,000 first person you're seeing to help you recognize what's going on. The more early you are in your career, the more you need to be slow and systematic, because you're not going to have the clinical experience that you're building on, because that's what you're getting right now. So what that means in mental health is that you've got to be really clear with yourself that is so disconcerting, man, that you've got to be really clear with yourself that you have fulfilled the diagnostic symptom criteria, that you have got the time requirements right, that there is something that looks like dysfunction, taking an overdose is dysfunction, and that you're pretty confident it's not related to something else, right? So you want to be walking that through in a really sort of clear and slow logical framework to make sure you can get to that. The other thing, of course, it does is it helps you with prognosis. Yeah. So major depressive episode has a different prognosis to recurrent depressive disorder, has a different prognosis to double depression. Yeah, has a different prognosis to dysthymia. Yep. So different diagnoses, and part of the reason for that kind of splitting out is cohort studies talk to us about different prognoses, what's going to happen. And obviously we're going to intervene, and that's what we're going to do in management. The purpose of intervening is to improve that prognosis, right? And the only way we can really be sure about improving prognosis is by having a look at large-scale trials, cohorts, and see what happens when we do X, whatever X might be. And X might be delivering CBT or helping someone with their housing or giving them a tablet. And so we need to be relatively confident that there's some science to show us this is the best thing to do. One of the realities of medicine is it's a bit like learning to be a builder, right? So this is kind of like literally an apprenticeship year, and a lot of what you will do will be based on what you will see your senior colleagues do. Some of it you'll go, I really want to do that, and some of which you'll go, oh my God, I never want to do that, right? So you're going to observe and practice under senior colleagues who are going to help you learn some stuff, right? But also it's important to be mindful of the science, right? Sometimes what we do is not the right thing. It might even be the wrong thing to be doing. But all we can do is build on what we know. Yep. So we no longer put leeches on people to extract the poisons from their blood because we know it doesn't make any difference. Yeah. Just like, if a baby has a big Brady on a CTG, we whip it out. We don't leave it in utero, so there's a stillbirth. We do these things on the basis of knowledge. So about 3 years ago, there was a nice paper published in the New England Journal of Medicine that showed convincingly that after you've had 3 steroid injections into your shoulder for a stiff or sore shoulder, your long-term prognosis is worse. But that was absolutely standard clinical practice to that point. No one had done the randomized control trial to show it made a difference. Yep. And so what we do is what we do because the body of understanding says that's what we do, but some of what we do might not be the best things to do. And so you kind of want to hold that stuff in your head too. So be orderly, be clear. And the reason you're being clear is so you can predict what's going to happen and intervene in a way to make it better, albeit that you want to spend a bit of time having a look at the evidence. And one of the nice things about 60 is you can really do that. So you should see some patients who you're going to write some formulations on and present some case histories. So you might go, I want to go and see, So if someone has an eating disorder, because I've seen Sally and she's been admitted to the ward with her eating disorder again and they force her to eat, is that really helpful? Go have a look in the literature, see what it says. Yeah, so you've got a bit of time to do that this year. I'd encourage you to use it. This is my list of diagnoses and differential diagnoses. There are some problems with this. I'm an addiction psychiatrist, but I do not see an alcohol or other drug use disorder as a differential, and it definitely should be. I spent a year working in an eating disorders unit, but again, I haven't put eating disorder down here, and it probably should be, right? And so although I keep wanting to change this slide to make me look better, this is the reality of things, right? I just wasn't paying enough attention when I did this, and it shows. And so you'll just got to be mindful if you're not focusing hard on what you're doing, things won't go well. I don't think you need to worry about that, other than the fact you practice in a system, so you need to be aware of the limits the system requires of you. Yep. And some of what you do is going to be not based on good science, not based on what you think and know, is going to be based on the constraints of the environment you're in. Yep. And so if you ever go and practice in, I don't know, Papua New Guinea or Ghana or, Burkina Faso, you may find that what you're doing is quite different from what you do here because there are resource constraints that make a difference what you do and how you practice. At this stage of the game, you don't need to spend a lot of time thinking about this, but it is something to, be aware of. Right, let's talk about our formulation. I'm mindful of the fact it's 10 past 10. I'm going to try and get finished by about 10:40. So you guys have got a 20-minute break before the world of different stuff at 11. And so what I want you to do is just have a little think about formulation. This is a kind of a key thing for you to learn. So if there's one kind of content thing to learn, it's this: how do I formulate people? And your formulations that you write and hand in every patient you see and formulate should be looking to answer this question: why does this person present with this problem in this way now? Actually, when you take a step back and think about this, we do this in medicine with every patient we see. Yeah. It's just that sometimes we're not very good at doing this with every patient we see, right? So actually, if we took a step back and stopped and thought about this question for Aunt Mavis, who's 74 and is admitted for the 3rd time with her right lower lobe pneumonia into hospital in winter, what we might realize is that the problem with Aunt Mavis is that she lives in a cold house. Yeah. Not that she's got pneumonia and needs more antibiotics. And because in quite a lot of what you'll see in various branches of medicine, we're not so good at stepping back and looking at the bigger picture, we sometimes miss the obvious things. So we give her antibiotics and send her back to her cold house, and she'll be back in 8 weeks. Yeah. And so, I mean, obviously that, we do think about these things, but that's the purpose of this. And actually what you're doing is trying to formulate what's going on for Aunt Mavis or whomever it might be. So in psychiatry, we do this in a much more kind of deliberate biopsychosocial way. And we do it in a way that emphasizes the kind of psychology of what's going on, as well as emphasizing biomedicine and thinking a little bit about someone's social context. So we're really trying to weave in all 3 strands when we think about formulation. And as part of that, I guess what we're thinking about is early life, what's set whoever up for whatever's going on at the moment, what's happened, which means we see what we see now, and why is it not resolved? So they're the kind of key ways we're thinking about this. And when you write your formulation and when you think about these things, the key thing to be thinking about doing is to integrate this information together. Yep. So last year, what we wanted you to do is identify the facts. What we want you to do this year is not only identify the facts, but start to link them together. Okay, when registrars do this, what I expect them to do is to link it together with a clear clinical frame that has an underlying theory that explains why they're formulated like they have, right? So that might be a social learning theory, that might be a cognitivist theory, that might be a biomedical theory, that might be an attachment theory, whatever it is. There'll be a theory that underlines what they do, right? And almost everywhere else in medicine is a hard biological theory that underpins our understanding of what's going on. Yeah. So harder to do in psychiatry because we understand the brain so poorly. What I expect of you guys isn't necessarily a theory that underpins all of this, although I tell you this so you understand why we're going about this process, just a kind of a clear, rational, logical, well thought out reasoning behind this. Another way of thinking about this is that what formulation is looking at someone's life through a clinical lens. Yeah. So what is it about the elements that I'm going to include in my formulation that is clinically relevant? Every time I ask a patient a question, what I'm actually doing with a little part of my brain is thinking, how does this help me understand diagnosis, formulate this person, think about what it might mean in terms of management? Yep. So that's the kinds of things I'm thinking about in my head when I see patients to work out what's going on. And the reason we kind of go through that process is sometimes if I miss the fact that, say, there's early trauma, what I'm going to do is miss the fact that simply sending them back home to wherever the trauma occurred is not going to work, or just telling them to do a bit of sleep hygiene might not work if the problem is significant on nightmares or whatever it might be. Yep. So those bits of information become useful in terms of clinical understanding that lead to management. So diagnosis, formulation, management, yep, kind of acts to link them together. Formulate 2 things I'd encourage you to do when you think about formulations is 1, you should be looking to write them in a way that you'd be happy to give them to a patient. And the reason for doing that, it helps us think about what of me am I putting in this formulation? What are my biases which are affecting the way I look at this? And again, as medical professionals, we're not very good at thinking about our personal biases. So if you see Aunt Mavis in the ward with her 3rd episode of pneumonia, and you had a grandmother who died in her cold house of pneumonia, you are far more likely to be aware of the potential social circumstances that are leading to her being admitted to the ward than if you've never had that personal experience. Yeah, you just can't help it. That's part of your reality. And so we need to be mindful of what bits of our own personal experience we bring to this. Now, what we know, because the epidemiology tells us, is that mental health, mental distress is common. It affects lots of people. We've already talked about that, you know, in New Zealand, for example, with alcohol and other drug use disorders. And so it is likely that many of us in the helping professions have had some experience of mental health, mental distress problems somehow, whether that's in ourselves and family members, whatever. And we're likely to be bringing some of that into this. Now, that isn't a bad thing or a good thing, it's just a thing. And it's something we need to be mindful of when we're formulating. So kind of a useful way to think that through is to go, well, if I was to give this to, you know, Johnny, who I've just written a formulation out, what would they think of it? It also helps you try to figure out what is it that I'm bringing this, that I'm making some assertions about clinically, but I could actually go and find out. So, you know, if I'm going to assert that Janine's history of trauma, you know, poverty is an important part of her current presentation of, and I think it's depression. And I'm not sure if those two things are really linked. I can go find out, right? You can go to the library, you can get into Google, you can go find some papers or have a look in Cochrane, the Systematic Reviews database, to see if there's evidence that supports your thinking. Yeah. And so I hope you'll have time over the next 4 weeks to do a bit of that. Yeah. So one thing to think about when you're on a formulation, give it to someone. Second thing to think about is, have I made enough linking or integrative statements here? So the sorts of words that talk to integration are things like, I wonder if, I'd hypothesize that, it could be that, maybe this, I'd speculate that. Those sorts of words are linking words, and they help us to understand what's going on. Is that about as clear as mud to people? So now I'm going to get you to do it with Janine. So it's 10:17. And what I'm going to ask you to do after I've gone, so you guys can fight without me, is to choose who's going to present this. And I'm going to get whoever that person is, hopefully I can figure out how to do this, to share their screen so we can all look at it and have a bit of a think about the formulation that you're going to prepare as a group for me about Janine. So you guys clear about what you're doing?
Could we have the screen on her stem again?
Ta-da!
Thank you.
All right, I'll leave you guys to it. All right, so I can't do anything, it's your screen. All right, so do you want to maximize the size of this and then talk us through it?
And did you pause share?
Did I don't know.
But you can still see it,
Can you
right?
see it?
Yeah, we can still see it.
We can all see it, yep, it's fine.
Okay, cool. Cool. Okay.
Okay. So we split it into 4 categories: predisposing, precipitating, protective, and maintaining factors. In terms of predisposing, we started at her childhood and sort of went through her adverse childhood events, including having a single mother growing up, which means she only had one role model and one person to provide for all her needs. Her father abandoned them when she was 3, which means her idea of relationships may have been thought that they were fragile, or people are unreliable. She was left on her own a lot at the marae, so she probably didn't spend a lot of time with her mother or have time to develop a secure relationship with her. Her mother also had depression during her childhood, which could lead to insecure attachment, which is a risk factor for developing mental distress later in life. She's had poor self-esteem, many brief, intense relationships, which could indicate that she builds unstable relationships. She has the family history of depression, which also may genetically predispose her, and as well as becoming pregnant at 16 and struggling as a young mother, single mother, and young mother.
No, I'm just going to stop you. Just going to stop. Oh no, keep going.
Okay. precipitants, which we thought were things that were directly leading to her presentation, was her 3-month history of general ill health, the end of her relationship, and the fact that she thinks she might be pregnant, which adds stress to her life, and the overdose.
Do you want me to do something? Okay, so we also thought about some protective factors that might, maybe we should do maintaining factors first actually. So in terms of things which maybe like maintaining her presentation could be the poor relationship with the social workers, meaning that she doesn't feel well supported and she's less likely to engage with them. She also discussed that she has low self-esteem earlier, and that might be something that's perpetuating the way that she's feeling and dealing with the episode. And then we've got as well, there was the involvement of the child welfare agencies with her child. So that could be like an added stress for her at the moment. And the fact that she's a single mother as well means that she might not have as good support networks in coping with this. We also thought a little bit about some protective factors that might improve her prognosis. We're thinking, we're not sure about the relationship with the father, so it would be important to learn more about that, whether this could be something that has a positive impact on her or whether or not. She also talks about having a relationship with one of the social workers, so hopefully we can maximize that to help her going forward. And perhaps we could also explore how she feels about her pregnancy and whether that's a positive thing for her and whether it's she can sort of maximize the way that and being a mother to her child.
All right, thank you very much, Min and Fiona. You don't get to pick on someone actually. I'm just going to pick on someone. So very briefly, Luke, what do you think is the strength of this?
I'm not entirely sure what you're asking, but
What do you like about what you've done? What do you think are the good things about it?
so given the amount of history we have, I think we've done a good summary of the predisposing events and different aspects of the history and we've kind of put them into their respective boxes to be able to more clearly think about it.
Okay.
We've also got the starting of thinking about other things like how things like the single mother and other abandonment that may have resulted in her poor relationship building, and that may have led to some of her getting a bit of feedback. Some of her poor relationships that she currently has.
Okay. What do you think you guys could have done better? Any of you? You guys can see the slide? Can you guys see the slide?
Yep.
Oh, I haven't. Let's just pause himself. Okay, so I've done better.
So I don't think we quite got to the point of fully linking things across the different domains.
Oh, I'd agree with that. And so I think for me at least, the thing that you guys have done really nicely is to identify a bunch of facts. Okay, got no facts, it's pretty hard to integrate anything, right? So job number one is to kind of get the intel, and you've done that well. Job number two is then to figure out what the intel means. Right, and so for example, in quite a lot of the facts you talked about. You referred back to Janine's pregnancy. So 2 things to bear in mind there. One is that we don't know if she's pregnant. And so you do need to be a little careful sometimes about the extrapolations, the guesses that you make about people, particularly if it's about hard facts that you can fix. So she's not pregnant, all the stuff about pregnancy isn't really that relevant. The second thing is, if we think about her pregnancy, of course, there is a variety of ways that might make a difference. That might be very positive or very negative, or a bit positive and a bit negative. Yeah. And so it's important when you're thinking about this to think about what are the relative potential positives and negatives of how this works. So I think you want to be trying to hold both of those things in your mind as you go. Our formulation is iterative, right? So it will develop. And what we do is we start off with a best guess, which should be a clinically informed, ideally theory-driven guess based on comprehensive facts that we have. And as we get to know more about people, as we get collateral information, as someone improves, as we understand their will and preferences better, then we will iterate our formulation, rewrite it, change it, as we learn new stuff. Yep. Just as with Mabel, we might not have known in admissions 1 and 2 that she had a cold house, but by admission 3, we should be asking and finding out, right? And as we get the new information, then we will change our formulation to reflect that new information. At this stage of the game, the key thing is to do a bit of what you have done, identify the important facts, try and put them in a box to understand them. Then the next important thing to do is to work out how to integrate them. And that's really what you should be focusing on over the next 4 weeks. So again, we talk about this, the biopsychosocial model, sometimes the spiritual and cultural. I'm going to jump over this one formulation so this is kind of what you did. And I don't think this is a bad plan, right? And the reason I don't think this is a bad plan is it helps you to make sure you don't forget some critical facts. So obviously if somebody has an identical twin with schizophrenia, it massively increases their chances of having a diagnosis of schizophrenia, right? So you probably want to know that, and it is probably an important piece of information. You don't want to miss it. Or if someone is smoking, a 50 bag of weed a day, you kind of want to know that. You don't want to miss that. But this is not a formulation. What this is a way to categorize the facts and to make sure you don't miss something important. And then from this, you can go about writing your formulation. Oh, God. Just going to jump over that. So what I'm not going to do is talk about management, but these, if you need them, these are here. The reason I'm not going to talk about management is you should see lots of it over the next 4 weeks. So you need to practice formulation, but you should see management and be involved in what management looks like. For each of your formulations, and indeed the cases that you're thinking through, I would encourage you to do this, draw this little box out and figure out what goes into each of these little squares. Now, the reason for doing this is it helps you think about what are the management strategies I need to be aware of? What are the kind of principles of management that I've got to get into my head over the next 4 weeks? Because after this, you're going to head off into various other elements of medicine. Half of you are going to become GPs, and half the patients you see are going to be doing mental health management. So you need to be thinking about, what is it I really need to get my head around? When you talk about this stuff in the Viva, it's open season for us to talk back to you about it. So if you say you want to try CBT on someone, I might ask you, what sort of CBD do you want for this person's OCD or whatever it might be? So you've got to understand this enough to be able to talk to it with a degree of sense, because that's what you're going to be expected to do when you're a doctor. You're going to be expected to know and be able to engage with the stuff with a degree of sense. Now, I'm mindful of the fact it's just past 22, and then Tracy will be back at 11 o'clock. I think it's probably a good idea if we have a decent enough break so you can, go to the loo or get a coffee, do whatever it is you want to do. For those of you who are in the med school, you're welcome to come up to the department if you prefer, or you can stay where you are. It's I'm going to have a chat to Kerry about making sure we book a room so there's always somewhere for you to be. And you'll all need to log back on to the World of Difference site at 10 o'clock, 11 o'clock. Do any of you have any last comments or questions you want to ask me? Jolly good. All right. see you guys in 20 minutes time.